Thank you so much for that nice introduction, and thank you so much for having me this morning. I'm really excited to talk to you about what I do and what we can do for our patients with MSMDS. And thank you, Ahmed. That was a wonderful talk and really adds a lot to our understanding of what we can do clinically now for these patients. Understanding the basic science and background really will help us move it forward in terms of how we can treat everyone really well. Okay. So today I'm just going to start with talking a little bit about gut development and some of the clinical manifestations, primarily the malrotation, which is really embryologically the main concern that we have in terms of anatomy and issues that happen within the fetus. Then I'll spend most of the time talking about the lower GI tract because, as we've heard, that's kind of where we have most of the symptoms in our patients. I will focus a little bit on some of the upper GI symptoms and finally end with some of the feeding difficulties we see. So in terms of normal embryology, things happen pretty early on within the developing fetus. Within the first couple of months, the small intestines is formed, and we'll see it forming, and it comes out through the umbilicus, through the belly button essentially, and grows very large within a couple of weeks, and then twists and comes back into the stomach. And this, by 12 weeks, it kind of should assume its position that's normal within the abdominal cavity. What can happen, though, is something called malrotation, which we can't see in many of our patients. And that's where the small intestines doesn't come back in and rotate appropriately. And so what we have is we have the small intestines. Over here, this is the normal one where you see it's kind of central on the left side. And malrotation, we'll see it more on the right side, and these bands that connect it to the abdominal wall can cross over the small intestines. This happens in individuals in general, and the incidence is thought to be 1 in 6,000, although many patients who have malrotation don't have symptoms. And so we think that this can actually happen much more often and be an up to 1 in 500 people because it's just not tested for often. However, in patients with ACTA2 mutations, we see it at a much higher rate. So up to 30 to 50% of patients with ACTA2 mutations are found to have malrotation. And the presentation is typically pretty early on within the first 5 years of life, and they'll usually present with various symptoms. The two most common symptoms that patients present with malrotation are related to vomiting. So what we'll see is often we'll have this kind of intermittent vomiting where parents will bring in their child and say that the kid's kind of spitting up. It can be kind of like regurgitation, or we think it's kind of like reflux in the babies. And it's often missed because it's not that pronounced. And it's because of these bands here that are cutting off the supply to the small intestines, but it goes back and forth. And so you'll see a little bit of vomiting, but it won't be that forceful. And this is more kind of the mild presentation, but we do think about it often in patients when they come in with reflux, particularly in the infant years. However, it can also present with something called intestinal volvulus, which presents as very severe vomiting. And what happens here is you can see the colon will twist around the small intestines. And what happens here is you can lose the blood supply and the oxygen to the intestines, which therefore can lead to very severe consequences from that. And this is a surgical emergency. And the patient will present with very severe vomiting. Often it could be bilious, meaning that it's yellow or green, and they can get very distended and ill. And so in these situations, we certainly want to intervene quickly. So in terms of making a diagnosis, we can use an ultrasound, but the what we call the gold standard, the way that we really make the diagnosis, is with an upper GI series. And we do this by having the patient swallow contrast, and it goes all the way through the small intestines and towards the end of it, and we can actually see where the small intestines is located within the abdominal cavity. And this will give us information if it's located in the correct area. One of our thoughts is, with many of the patients of MSMDS presenting with malrotation, is there a role to do more screening of upper GI series because we know it's such a high incidence? Should patients who have any form of vomiting, particularly with MSMDS, have an upper GI series? And that could be reasonable. The treatment is something called a latch procedure, which I'm not going to go into detail about, but essentially these bands are cut in the small intestines is rotated appropriately and placed back into the abdominal cavity, preventing the further symptoms. So that's something we always think about in our younger patients, particularly those presenting with any type of vomiting. I'm not going to spend much time talking about the smooth muscle because Ahmed did talk about it in depth, and it's certainly what's been talked about this whole conference, but it really affects the GI tract. And because of the way that it pushes things through, and Ahmed spoke about it, we have both the peristalsis, which is kind of that forward movement where we get those contractions of the smooth muscle that propels both the nutrients in the food along and the fecal matter in the stool and the colon along, but also the smooth muscle causes these intermittent contractions that help with the digestion and absorption. So when there's an issue with the smooth muscle, we see issues with the effective movement of the air and the nutrients through the bowel and the absorption. So just for 1 minute, I want to just mention these other syndromes that also present in similar ways. We have MMIHS and then SIBO. And this was just a paper that was published a few years ago, just looking at the various mutations that will cause issues with these visceral myopathies. So MMIHS, megacystitis microcolon intestinal hyperperistalsis syndrome, is a functional obstruction. So there's no blockage, but it seems like there's a blockage in the GI tract, and it can cause both urinary and GI symptoms. So these patients present with a really dilated bladder. Their colon can be very small and underdeveloped, and they have very minimal peristalsis. So somewhat of a similar presentation that we sometimes see with our MSMDS patients. And then we have the chronic intestinal pseudoobstruction, which is kind of presents differently in that you get really dilated bowels. And this is thought to be more to also because of this muscle weakness, but there's such a lack of strength to those muscles that everything kind of sits in them. So it seems like there's an obstruction because things aren't moving along, but it's more because we don't have the ability to move things along. And so patients similarly will present with feeding intolerance, vomiting, and issues with constipation. So back to our patients, the ACTA2 mutation, as we know, it's an issue with actin and causes problems with the smooth muscle, and you can get dysmotility of the gut. We often see this in the small intestines and in the colon, but there have been cases of upper GI symptoms too. There's a significant overlap that's been found between MSMDS clinically and the MMIHS and SIBO patients because they both present kind of with these GI symptoms pretty early on. Although the MSMDS patients can have other issues, particularly the vascular issues, although it's noted in the literature that these the vascular issues present later on in life, and so often our younger patients can get misdiagnosed younger because they have similar clinical presentations as these other disorders. And there's a variable penetrance, which has been mentioned, so you'll have patients who have the exact same mutations that clinically, from a GI perspective, one may have very severe constipation and require many medications and interventions, and another patient who presents only with mild constipation, even though there's the same mutation. And this just reinforces that we have to really understand this further, as Ahmed was getting at. So now to spend some time talking about the lower GI tract, kind of where we have the most symptoms. Patients can present with all different types of clinical symptoms, including bloating, abdominal pain, watery diarrhea, gassiness, infrequent bowel movements, distension, and fullness. There are multiple differential diagnoses within these patients that we think about. One of them I just want to touch on briefly is a pseudo-obstruction not caused by a genetic background, but just kind of that presentation that I talked about, where you can just get these really dilated bowels, particularly in the small intestines, thought to be due to an issue with motility. And then the other one is small intestinal bacterial overgrowth. And that's an interesting area where we think that there's excess bacteria in the small bowel because of an issue of movement of things through the gut. And so what happens is patients will have this extra bacteria that leads to symptoms of gassiness, distension, and we test it with a breath test and then treat with antibiotics, and that usually helps it. But an issue with our MSMDS patients is that we still have the issue with dysmotility. And so even if we treat it and that improves, we still continue to have problems that this can come back. The most important thing, though, that I want to spend the most time talking about is the constipation, because from the patients that I see with MSMDS, that seems to be where the biggest challenges are and kind of the biggest concerns I have with my patients. So in terms of constipation, it's been reported in the literature that up to 37% of patients with ACTA2 mutations have constipation. I personally believe, based on the patients that I've seen, and just in general, and based on the basic science research, that it's probably a much higher percentage. And I think that also stems from the fact that everyone has a different definition of constipation. And I think that makes it trickier for us to really understand how constipated patients are. I just put this up here because this is what we use often in our GI practice. It's called the Bristol stool chart. And anytime a patient comes in and they say, I'm constipated, I'll say, okay, well, tell me about your poop. And so this is our way of kind of trying to define the different type of poop that we have. And so usually the type 1 and 2s we consider constipated, and those are really the hard bowel movements, the ones that are painful. The other thing we always ask about is the frequency. You know, frequency of stool can be wide ranging. We have patients who will stool 3 times a day, and then others who will stool every few days, and that can all be normal for them. It's when it becomes really painful and difficult to stool, or really infrequent is when we get more concerned. And when we think about constipation, I just like this picture because it kind of breaks it down a bit. We have normal, these are the stool balls going through. And then we have the stool balls where things are just going through slowly. And we call that slow transit constipation, where it kind of doesn't, it gets stuck within the colon because we think there's an issue with contractions and moving things along. And then we have something called outlet obstruction. And that's where it gets all the way towards the end, but kind of gets stuck at the end. And so patients will say they're straining or they're pushing really hard and they can't really get it out. And we think they might be caused by different entities and different ways that we look into it. So the first question always is, okay, I'm constipated. What can we do to work this up? So a KUB is an X-ray. Do we just take an X-ray of the stomach? Is that going to help us? And I'm always torn about that because I don't think an actual picture is that accurate, because everyone has different amounts of stool. And so studies have shown that if you show a picture to a radiologist with poop, everyone will say there's different amounts of poop in it. And so I don't love to go by X-rays, and blood work honestly doesn't really add that much. Neither does a colonoscopy, because that's not going to necessarily change how we think about things. We know what one of the issues is with ACTA2 mutations. We know there's an issue with the smooth muscle. And so adding things to it doesn't really give us additional information. So one of the tests that I do think is helpful is something called a Sitzmark study, which some of you may be aware of. And that's where we have patients swallow these capsules, or you can open them up and they have 24 rings inside. And then essentially what we do is we get an X-ray on the 5th day and we say, okay, how fast did those rings move through? We call it the medicalized version of a corn test, because corn comes out in the stool easily formed, so you can see when you ate it last. But this is our way of actually taking a picture and seeing how fast are things moving through the colon. And so these are just 2 examples of what we can see in issues with constipation. Here you can see this is, these are the rings kind of staying more on the right side of the colon. The colon goes all the way here and comes down. So they're kind of stuck on the right side. So they really haven't made their way through at all. And these are patients that we think maybe there's slower transit within the colon. This is an example where we think they've made their way through pretty well, but they got stuck towards the end. And you can see they're kind of all at the very end of the colon and the rectum just sitting there. And so maybe this is more consistent with an outlet obstruction. It's just our way of really understanding if there's a backup at all. In healthy individuals, all of those should be out by the 5th day. And then another way that we look at constipation is looking at the outlet. And that's kind of once things get to the end, what can we understand then? So just quickly, when you're defecating, which is what I think about a lot, what needs to happen? It's true, but I talk about it all day. So when you defecate, this is your colon, and the stool, you get the urge to defecate, and the stool comes out here. You need to get the bear down of your stomach, and you also need the pelvic floor to relax. So you can see here, when you think about it, you're pushing down, your pelvic floor goes down, and you get an elongation of the end of the colon, and it kind of straightens out to make it easier for poop to come out. And so we have ways to actually test this. We have something called an anorectal manometry, which is this. We put a catheter with a balloon in, and it gives us a lot of information about that end of the colon, the outlet. It can tell us how the sphincter, this is the end, how that's working. You know, is there an issue with, I was just talking to Dr. Goldstein, do we know that much about the end of the colon? I think we're still kind of trying to figure out the sphincter at the end. Is that sphincter tighter than typical? You know, is that there's part of the smooth muscle is associated there. Could there be abnormalities there? So doing this test could give us information there, and then also tells us about how those muscles are working and how we're sensing things. If there are abnormalities, we do have interventions that we use. One is a Botox injection to the sphincter. Sometimes that helps relax it. And another is using pelvic floor physical therapy to work with those muscles to help get it out. So these are medications. I'm not going to go through all of them, and many of you have probably heard about them. But these are a bunch of medications that we use to treat constipation. Just briefly, we have our fibers, which are the bulk-forming agents that help to kind of bulk up the stool. Our osmotic agents bring water into the stool. So those are things like Miralax that make the stool just more watery to help kind of make it softer and easier to come out. The ones I focus on the most are the stimulants in my patients with MSMDS. The stimulants are the ones that actually help with the contractions. So with our active 2 mutation, we know that those smooth muscles, as we just saw, really aren't contracting that well. We kind of get these abnormal contractions. They're not that strong. So the stimulants are really the ones that we hope will kind of emphasize and increase those contractions and help get things moving along the colon. So those are things like Senna, Xlax, Dulcolax. We do sometimes rely on rectal therapy. Those are the enemas, the suppositories, and those can help get things that are stuck at the end. I have had patients who there's a question if we should use it there, is there a high risk of perforation? It is insertion of something into the rectum. And so there was concern in one patient about perforation, and so we just are cautious about using that. And then there are prescription medications, which are the newer ones that work in different ways to help get things moving. And then finally, I just want to talk for 1 minute about something colonic manometry, which is kind of the other version of what Ahmed was talking about with it they were doing in the mice. We do that in the colon. And those are severe cases where we really can't get things under control. And what we do is we take a colonoscope, a colonoscopy, and place a catheter all the way through the colon and measure it for 6 to 8 hours and see what the colon is actually doing. So this is just a picture of the catheter going through all the way through the colon. And then we can see the contractions that happen. And it helps us understand where there are areas that aren't contracting well. We don't like to take out small portions of the colon in any patients, but particularly in patients with MSMDS, we think it's involving the whole colon. And so the concern about taking out a portion is we're still dealing with issues in the rest of the colon. So what we'll often do more commonly if we're in really severe situations is something called a cecostomy or appendicostomy, where we put a little tube, make an incision here surgically, and are able to flush the whole colon. So if we're dealing with a colon that's not getting things through, we're able to kind of flush it through with a clean out often so that the poop doesn't just sit in there and get backed up. So that's kind of the constipation perspective that I think from what I see is really the most cumbersome and causes the most morbidity. But I do want to spend a little bit of time talking about the issues with gastroparesis in the upper GI. As Ahmed said in the last talk, there's not a lot of data about the upper GI causing issues, but I do have patients who will have complaints with the upper GI. So gastroparesis is essentially slow movement of things through the stomach. And so we were just talking about slow movement of things through the small intestines, slow movement of things through the colon. We have, there we go, small movement of things through the stomach. So these patients, unlike the constipation patients who usually present more with issues with pooping, these patients present more with issues with nausea, vomiting, or early fullness, meaning that they take a few bites and they get really full. In a healthy individual, the stomach empties usually within 4 hours. That's kind of normal. Patients with dysmotility of the stomach, it can take much longer. And so you'll see kind of food just sitting in there for a while. The way we assess this is through something called a gastric emptying scan. And what that is it's a standardized test of eggs, toast with jelly on it, which I find to be a pretty funny choice, and it's standardized throughout the country because when someone's feeling not well and nauseous, an egg sandwich is not typically the first thing that they want to eat. But that's how we do it, and that really gives us the best information because it is standardized. So the data we get can be compared to people throughout the country. We do have a way to do it with liquid, but that doesn't have standardized values. So what it is this sandwich is actually radio labeled. So that means we can actually trace it as it goes through the GI tract or the upper GI tract. And we'll take pictures at 1 hour, 2 hours, and 4 hours. And then we'll see how fast is it moving through. We would expect it to all move through by 4 hours, but in patients who it's not moving through well, it can take 5 or 6 hours. In terms of treatment, we do behavioral things like diet. So we'll say, okay, try eating smaller meals throughout the day. That might make you feel better and you can tolerate it better rather than 3 big meals. And then we have a few medications that we use. One is called erythromycin or zithromycin, and those are antibiotics you may have heard of. And those we use at a lower dose than we use as antibiotic treatment. And that's for 2 reasons. One, it doesn't affect the GI tract as much, so you don't get those like nausea symptoms or diarrhea that you get from antibiotics. And it prevents an issue with resistance to antibiotics. And we do have patients who will take that for an extended period of time. Then we have a medication called metoclopramide or Reglan that is, I think is actually one of the more effective medications for gastroparesis. But it is concerning because it does have a side effect that is rare, but can be more severe and long lasting. The newer data, though, is showing that it's not that common. And so in patients who are really struggling, we do use this medication more. And then this is propalapide, which I didn't talk about in depth during the constipation section, but it is an important one to note because it's our newest drug, and it is the most effective in terms of pro-motility for constipation medications, and also helps with, we think, with the small bowel and with the stomach. And so we'll use it sometimes for patients who are having issues kind of throughout their GI tract. It's the same class of a drug called cisapride, which is around a few decades ago, no longer approved in the United States, but now this is the newer version that has less side effects associated with it. And so one that you may have heard of in general for treatments. And then there's reflux. So up to 30% of patients with MSMDS have reported reflux. And what reflux is here's a nice little picture of it. It's when the gastric contents go up into the esophagus. And so you can see here, the stomach has a lot of juice in it and it's pretty acidic. The esophagus should not have that much acid that comes in because it burns the mucosa. And so what happens is when it comes in here, you get a lot of symptoms because the esophagus is saying, oh, there's so much acid here, it's really uncomfortable. And then the question also is there is a sphincter here, which is a tight muscle. And the question is the sphincter relaxing more often in these patients? Or is there an issue here that might be causing more acid reflux to happen? And that's why we see it in up to 30% of patients. The symptoms can be heartburn, regurgitation, feeling like acid in the throat. We diagnose it usually just based on symptoms. And sometimes we call it empirically, we'll just treat it with medications and see if you feel better without doing actual testing. But there are other tests we can do. We can do an endoscopy, which is where we go in with a camera, we look around, we can take some biopsies, and we can see if there's an abnormality in the mucosa. Or we can do something called a pH probe. And that's where we actually put a probe in the esophagus to see how much acid is coming in. And that can help us understand, are we having excess acid coming into the esophagus? And that's why we're having symptoms. In terms of treatment, there's various different treatments you're probably heard of. There's Tums, which is fast acting, an antacid that kind of just neutralizes any acid there. So it works quickly, but it doesn't prevent acid reflux. And then we have H2 blockers and proton pump inhibitors, and those are more preventative and can help prevent symptoms of reflux. And then there are behavioral things like dietary changes, position changes. And then in the last part, I just want to focus a little bit on feeding difficulties because that's something that we do see in our patients with MSMDS. There's pretty limited data in terms of why we think this is happening. We have various factors that we think can contribute to it. One of them is just the muscular strength in general. We have, smooth muscles throughout the GI tract. And so are there areas that are being affected we just don't know about? So the actual act of initiation of a swallow is mostly skeletal muscles, but there could be smooth muscles there within the sphincters, within the esophagus that are affected that will cause problems with, we call dysphagia, difficulty with just swallowing and getting stuck in the esophagus. Could there be some contractions in the esophagus that might be abnormal? Or that we talked about before, this kind of things just sitting in the stomach and not being able to get through. And then as mentioned, the small intestines and the colon are certainly affected. So for evaluation, there are different ways we can look into it. We can do something called a VFSS. That's really just looking at the contractions as we initiate a swallow. And then there's something called a barium swallow, which is where we swallow that contrast, like an upper GI series I mentioned, and can actually outline it and see how things are moving through. Is there some issue with going into the esophagus and the stomach? And then finally, like the other manometry studies that I mentioned, we have a way of checking the contractions in the esophagus. So that's a catheter that will actually see, do we have a low strength in the esophagus too? There's smooth muscle in the esophagus. Is that being affected too? And that's causing issues with swallowing and tolerance of feeds. So we do, in patients who have problems with feeding, we have ways to support them. So we have our gastric feeds. So that's either a nasogastric tube or G-tube. So the nasogastric tube will go through the nose all the way into the stomach. Or the G-tube will go directly into the stomach. And then we have small bowel feeds. That's either another NJ, which goes all the way down into the small bowel, or a GJ, which connects both the stomach directly and the small bowel through the abdominal wall. The small bowel we tend to use only when we're having issues with the stomach. We would love to be able to use the stomach if we can. And so unless there's really a reason that the stomach isn't working, like really bad gastroparesis, we try to have every nutritional contents go through the stomach. That keeps the stomach working. The less it's being used, the less it works. And so we really try to keep that, but there are cases where we'll have to bypass the stomach. And then there's always questions about dietary considerations. Again, we don't have great data on it. But what we say in GI in general and with patients with MSMDS is we really like varied diets. We don't like to take too much out of the diet because there's no data to really support removal of things. And there hasn't been data to say, take gluten out and that's what helps. Take dairy out and that's what helps. If you, as a parent, say, I'm going to take this out and my child is feeling better, by all means do that. But we as clinicians don't have a way to say, okay, this is what's going to help you at this point. And we know from allergy data and just data in general, having a varied diet is actually much better for the body because we're exposed to many things. It decreases allergies, and it really helps us kind of with digestion in general. Allergy testing is always a question we get. In these patients, we have no reason to think there's an allergy component specifically. And so it's often inaccurate and parents will come and say, I got this tested, but we don't really know what to do with that. So unless there's a specific concern, we say to avoid that. And then this is something that we always talk about in motility is something called visceral hypersensitivity, thinking that the viscera or the lining of the GI tract, that the enteric nervous system is in a hypersensitive state. And so maybe some of the symptoms that we're experiencing are actually due to the nerves as opposed to an issue with an allergy or some other component of things. So to summarize, there is a lack of data clinically in terms of MSMDS regarding the specifics of the GI in relation to the pathophysiology. We have a lot of great basic science research going on now in terms of really understanding things. And we have a lot of great clinical understanding in general of dysmotility. But I think with active 2 mutations, there's a specific abnormality that we're trying to focus on and trying to understand, but we're still kind of at the beginning of clinically understanding how best to treat our patients. We do know that it can cause a lot of morbidity embryologically with the malrotation. Dysmotility is the main issue, and constipation, from what I've seen, is really kind of the mainstay in terms of symptomatology. I always advocate for more aggressive treatment with constipation. That prevents complications in the future because we don't want issues with stretching of the colon where the colon doesn't work as well, and then we're really stuck. And so I always encourage parents to really use medications and interventions to treat early so that we aren't dealing with complications later on. We also have the issues with gastroparesis and GERD. And then the feeding difficulties, which can be due to dysmotility, and we should manage as best we can. And thank you, and I'm happy to answer questions about it. Oh, I'm sorry. I also have my email address, so if you guys have any questions or anything, feel free to reach out too.
Is there anything in the chat? Thank you so much.
Yeah.
I think it's the first time I don't see you with scrubs.
Exactly.
It's awesome. And thank you for taking care of these patients. They're including a series of things that are complicated to handle at the same time, and sometimes the procedures, a lot of families I will expect here in the room have had to face the GJ, and others just like trying to deal with constipation. I wanted to ask you, is there parameters on tolerance when you said like treating constipation? I think also I agree completely. We've seen perforations happening, pseudostruction / perforations. So their consequences can be really severe from letting the stool sit there, and the kid may not complain that much. These patients are not in severe pain until they perforate, so they might be putting up with it. What are the early signs? Do you have any parameters of if the kid was stooling, how much change you tolerate before you ask for an X-ray or
no? I think it's a good question, and I think one of the issues we have is a lot of our patients have had these symptoms for essentially their whole life, and so it's hard to kind of assess when things are getting worse or when we kind of need to intervene more. I do think it's important to speak with your doctor about it. X-rays, I don't love them in terms of assessing how much poop there is inside, but I do think they can give us a baseline of kind of how dilated things are somewhat, because you can get a picture and see kind of how stretched out that colon is. And so I think if we have a patient who kind of for most of their life has been having issues with constipation, I think to get a baseline understanding of it could be helpful. And we do that. Sometimes we'll do X-rays, and sometimes we will do contrast studies just to get an assessment as a baseline how much we're dealing with. Every patient is different, so I think it's hard to give a parameter and say, okay, if they skip a day, then we have to be concerned. But ultimately, my biggest thing is I want our patients to be comfortable. And so if there's any indication that they're still struggling with getting poop out, or there's some discomfort, it doesn't have to be severe. I do think using medications to kind of get to a point where it's easy to get that out is a good goal to be at. So I don't think we need to wait till it's extremely severe to do any intervention. I think when we even have mild to moderate symptoms, we should be trying to treat that to get it to the point where it passes easily.
I have another question.
Yeah.
Eosinophilic esophagitis. What's that? Why?
Yeah, it's a good question. So the newest data, there's not a ton about it in relation to ACTA2 mutations. What it is thought to be an immune response to an allergy, essentially, but not an allergy we can test for. And what you get is you get extra immune cells in the esophagus, something called eosinophils. And what that happens then is because you have so much of this inflammation in the esophagus from these immune cells, is you can get chronic inflammation, which actually leads to narrowing of the esophagus. And so that can cause contractions of the, or what we call strictures of the esophagus, or things can kind of get stuck. So if we are having patients having feeding difficulties, that's where the endoscopy could be helpful to really understand if there are things that might be abnormal. And the only way to really diagnose that is by going in and looking. We don't have like blood tests or anything to assess that.
My son has that, and gluten is his trigger, and removing gluten totally changed his whole GI system.
Yeah, and it's interesting. So it's not so. To get more into that, eosinophilic esophagitis, the treatment for it, because we think it's allergy or kind of exposure related, is we'll often take out various food groups. So in that case, for example, I don't recommend just taking one out, because what happens then is you take it out and maybe they get better, but we don't have an actual diagnosis for why. And so in those cases, I certainly think doing like an endoscopy, looking for other GI causes like celiac disease or things like that, to get a diagnosis is important before we remove things from the diet. But certainly dairy, gluten can certainly be.
Can you talk a little bit about dietary fiber and
Yeah.
fiber supplements?
Yeah.
Is that encouraged or discouraged?
Yeah, it's a good question. So fiber is it's kind of our initial thing that we do for constipation in general. And I think it's appropriate along with just hydration. Water is a good kind of initial intervention. What fiber does, it can be a bulking agent, so it gives some more bulk to the stool, which actually helps move things along. I think with our Active 2 patients, because we have poor contractions in general, I don't want us to just say, okay, fiber is going to be the thing that changes it. So I'll have many patients who, we just say, okay, more fiber, more fiber. I'm not sure that's going to be the thing that actually helps with the contractions to move it along. But I do think giving some bulk to the stool is helpful. And I think the data from pediatrics, not in MSMDS patients, but just pediatrics in general, is that fiber is not that effective for constipation. Many kids typically have somewhat of a balanced diet with enough fiber. If we can get more fiber in, I always encourage it, but it is a balancing act because too much fiber actually can worsen symptoms because we get too much bulk to it. So we have parents come in saying, oh, all they eat is salad. Well, I'm like, well, of course they're uncomfortable because they're constipated, they have gas because it's not digested well. And so you get kind of more issues with it. So it's kind of this balancing act of making sure we're getting decent amounts. I'll also tell parents, getting one more apple a day or one more vegetable or whatever, if you do feeds or whatever, getting a little bit more fiber in is not going to dramatically change the constipation. And particularly because we know there is that smooth muscle issue, I'm not convinced that kind of changing fiber will significantly kind of move the needle.
I was thinking more in terms of like fiber gummies. Some of the kids take fiber gummies, but what I'm hearing is that there's sort of an optimum level.
Yes.
More on the lighter side than
exactly. And what I do find also is that in general, every patient is different. So I will have patients say, I'll say try fiber gummies, certainly appropriate to try. And one will take 1, 2, 3 and not notice any difference. And then I'll have a patient who takes one and is completely backed up from it. And so I always talk about fiber. I think it's an appropriate thing to try because it's pretty, we say benign. Side effects aren't too great. Other than the fact to be very aware that if we're getting more constipated, having more gas and more distension, we should pull back. Yeah.
Back to the EOE portion of it. So we were told that our daughter may have EOE.
Yeah.
We were told our daughter might have I guess she was diagnosed with EOE, but then they weren't sure if it was part of MSMDS that caused the EOE or an allergic reaction. They wanted to treat her, putting her on oral budesonide.
Yeah.
But then I think from the last conference, there was mention that they don't see the need for it, or it could cause yeast overgrowth and cause more issues.
Mm-hmm.
So what is your suggestion with trying to treat the EOE, because she does have strictures?
Okay.
But it's also very random as to when she can pass a food or when she can't. And sometimes she'll be eating a Dorito and she's perfectly fine.
Yeah.
And we've been told to give her soft foods, and sometimes she's choking on the soft food. So it's kind of hard to gauge.
So my opinion is EOE should be treated. I think the newest guidelines that came out last year are very into treating and monitoring too. So they'll encourage repeat endoscopies. And now we have kind of endoscopies that can be done awake, which will give us some more information. I think it should be treated. If your child is someone who can tolerate dietary changes and, you take one food group out and you find like the gluten's it and they're great, wonderful, But if you're taking out dairy and gluten and meat and all these things and they're still having symptoms, I certainly think medication is appropriate. Yes, there's side effects for medication that we're always concerned about. I have many patients on swallowed budesonide because it just doesn't work to do the dietary changes for them. And that's fine. If that's what works best for your child, I think that's completely appropriate because I would much rather have the risk of the yeast infection than the complications from EOE. And then there's Dupixent, which is the newer drug, which has been getting easier and easier to get approved, which is the once a week injection, an immune therapy that actually works really well in EOE. And so that's what we're leaning more towards in the patients who have been on swallowed budesonide for a while and either having complications from it or can't tolerate it, then we move on to that. So there are a lot of options. I would encourage, though, to do appropriate treatment, particularly if there's a concern for stricture.
Yeah, we've done the endoscopy. The last one we did was back in October, I believe, or November.
Yeah.
But then they didn't think that she would be a good participant or whatever
Oh.
for Dupixent.
Wonder why. I don't know.
I honestly don't remember.
I don't know. I
Went through
tried.
a lot since then.
Yeah,
So-
I'm not sure. We try in our practice, we try to get, I know insurance is the biggest issue. That's what, we work with a lot. But most patients we think could tolerate well, unless there's some like asthma or allergy can sometimes be one of the contraindications.
They did recently diagnose her with intermittent asthma.
Yeah, that's still, it has to be pretty significant, but we can, yeah, I'm happy to chat about it later. Yeah,
Thank you.
yeah, no problem.
Hi, I just have a couple questions, I
Yeah.
guess. So our son is on the swallowed budesonide that
Yeah.
he swallows with syrup, which always throws hospitals off when he has a hospitalization. They're like, why do you need syrup?
Yeah.
But if he's doing, I mean, I guess he's okay. He has EOE.
Mhm.
He's had an endoscope twice.
Yeah.
They want to do another one to see like if it's any better or whatever, but
Yeah.
they're waiting for him to have to be sedated again.
Yeah.
Would you recommend changing it to one of the other meds for any reason, or not the injection? Absolutely not. He
Oh.
would absolutely hate that.
Okay.
He already has to get blood draws once a month. So I would rather not if we don't have to, but it's the other one you said that you guys see a lot of success with. We're still seeing some difficulties with his vomiting and stuff, which is what led us to find the EOE in the first place was all
Yeah.
his vomiting. So he still has occasional trouble with that,
Yeah.
and getting him to eat is like the biggest pain of my entire life. But so taking foods out is not an option.
Right.
But
Yeah.
there was one other med you said at the end that wasn't an injection that you said has had success.
No, it's the Dupixent is the injection.
Oh, okay. I thought that
No,
there was another thing.
That's the
Sorry.
most successful one. And data wise is the most successful. I would not, if dietary changes are inappropriate, I would stick with budesonide. I have many patients on it. I think we pick and choose what would work best. And I think it might be, and that's why it would be interesting what the endoscopy shows, is there are other reasons for vomiting, so we can treat EOE and it can resolve, but we still have symptoms. And then the newer data is trying to look at the motility within EOE, because we think maybe sometimes patients will have resolution on, biopsy. There's not the eosinophils, but are still having motility issues. So that could be something further down, but I wouldn't change the treatment if it seems to be working from kind of an endoscopy perspective.
Okay. I think it's working from an endoscopy perspective. I honestly
Yeah.
can't really remember, but is there any reason why we would need to stop it though? You said side effects, and to be honest, we started it a long time ago, and so now I'm like, wait a second.
No, we have many patients on it. I would say I have many patients on it long term. If I do change it, would be to Dupixent.
Okay.
But typically I won't stop it or go back to other things, particularly in kids who have difficulty with dietary changes. There aren't too many other options. It would just be if he had like repeated episodes of yeast infection in his throat. But if that's not an issue, then I wouldn't change anything. Yeah.
Great. Thank you.
Hi, Dr. Kessler. I have two questions. One is, I didn't hear you mention probiotics. Is there a role for probiotics? Maybe you did and I missed that.
No. Okay, no. So I didn't mention it. I think because it's somewhat controversial at this point in that there isn't data in the motility world to support probiotics specifically for motility. So I did initially have it in and then I took it out because it's kind of this back and forth. I would say probiotics are helpful in some immune cases. So like, for example, inflammatory bowel disease, like ulcerative colitis, Crohn's, sometimes we use probiotics. Occasionally with post-infectious, if there's like a bad infectious cause, we think probiotics help. There have been studies done in constipation and other motility issues with probiotics, and there's no data specifically to support that. That being said, I have patients who will say, I tried this probiotic and it's really helping. And I say, okay, that's wonderful. I don't have a concern about probiotics. I don't think in most patients who have a otherwise healthy immune system, there is a problem with taking them. I do think they're expensive. And so what I'll tell parents is try it out. If you're interested in trying it, you can try it out, give it a month, give it 2. But if it's not doing anything, there's no reason to stay on it for 6 months, a year, that it's going to suddenly do something. So anecdotally, essentially, I've had patients who say it helps, but we don't have kind of science and data to support that at this point.
So outside of probiotics, though, outside of for motility, I mean, we're kind of taught as a culture that probiotics play an important role in
Yeah.
gut health.
Yeah.
So I think I just heard you say you didn't have an objection to that,
Yeah.
but are there benefits beyond just?
Yeah, so it's a good question.
Probiotics.
The way I think about probiotics, and I think people do in general, is we're kind of at the infancy of understanding the relationship between understanding the microbiome and changing that into the clinical world. And so gut health is so important, and we're understanding the microbiome, but essentially what probiotics are often are kind of like a whole millions of bacteria that we're kind of like, we say throwing the kitchen sink. We're kind of just throwing a bunch of things in there and hoping something works. And I think we're working on trying to be more specific and saying, okay, in these diseases, we know there are abnormalities in these different bacteria in the gut, but taking that to understanding which bacteria to use and how that will stay in the GI tract, and how that, you can take a bacteria that's low, but will that actually form in the GI tract? Will that stay there? Will that change the balance of the GI tract? We aren't at that point yet. And so I think that's kind of where we, as clinicians, say, okay, well, there are some cases we have found that this is helpful, but a lot of the times we know there might be abnormalities within the microbiome, but we don't know necessarily how to change that at this point.
Okay, and then my other question was, so going back to sort of like the consistency, is that our daughter has consistency where sometimes she definitely has constipation, has difficulty with motility. Sometimes she'll go and it will just be a giant, I don't know what the medical term is, output.
Yeah.
Or it can be explosive,
Right.
like really upset stomach, explosive
Yeah.
all the time. And so is there concern with that inconsistently? Like she's consistently inconsistent.
Yeah.
And so that's the first part of that question. The second part is she takes cal magnesium, which is not listed in the list that you have up there.
Yeah.
And I just wonder if changing the choice of medication that we use with her, could that help with that piece?
Yes, so good questions. The first part in terms of the consistently inconsistent, it's better than being kind of having issues all the time. One of my bigger concerns is if there's just a backup of poop that's persistently there, because that's where we get the issue with the dilation and the stretching out and concerns like that, that's backing up and kind of just sitting there stretching out the colon. Inconsistent means that we are getting things out at some point, maybe not every day. It's often the schedule is frustrating because we can't kind of predict when we're going to have a huge explosive output or when we're not. So that can be frustrating. But I think I am happy to hear that we're getting kind of big outputs at some point. So we know we are clearing the colon fairly well. In terms of the medication, so I didn't put a magnesium column because it is in part of kind of, it's an osmotic kind of stimulant overlap, if you will. We use it often. We think it's kind of mild and works well in patients. It can also help with sleep and anxiety and things like that. So it's a great medication. But that being said, I do wonder if a different drug might be just a better option. There are a bunch of other ones, there's stimulants, which sometimes can be helpful, but there's also, I find, the prescription medications. They work in different ways, and sometimes it's just a matter of trying different ones out. And I have patients say, oh, wow, this one's so great. Like I'm doing much better on this than I was on the other ones. So I wouldn't necessarily stick with just one drug, even though it sounds like we're doing okay-ish. It might make sense to try a different one. And if those don't work as well, either go back. But there are many other options that it might be helpful to kind of just play around with it a bit.
Thank you.
I have a little bit of a complicated question for you.
Okay.
So, we were recently looking at some blood work for my daughter. Some of the clotting proteins she had related to vitamin K were depressed. And I understand that vitamin K is somewhat produced in the gut, or it's related to gut biome. If she's on extended days of azithromycin, what are your thoughts about people on extended antibiotics versus depression of vitamin K, which could depress clotting factors?
Yeah, so vitamin K isn't really produced, it's absorbed through the gut, but that's more within the intestines than the stomach. The antibiotics, prolonged, I think it's probably a lower dose than the antimicrobial. dosing, the antibiotics typically affect the stomach more than the small intestines. Could it be kind of affecting the microbiome? Sure. I think our understanding of vitamin K at this point though is more it's a fat absorption issue, and so it's absorbing the fat within the vitamin K, and so the antibiotics should not be causing an issue with that absorption. They kind of are two separate things. Certainly, I always have a concern, kind of as I mentioned, about the microbiome or the kind of antibiotic effect after an extended period of time. But that being said, when patients do have issues with motility of the gut, sometimes we do have to rely on medications, and that's why we use it at lower doses, because it's kind of our way of taking it, but not as such an extreme measure. But I don't think those two things are related.
There are a lot of these kids that are on prophylaxis either for the bladder,
Yes.
or for the lungs.
Yes.
So, and they tend to be on, I was saying that they're on prophylactic antibiotic regimens, many of these kids, either for UTIs or or the azithromycin is used a lot for the pulmonary. So I think also it has to be put in the context of all the other.
Yes, that's the reason why. Yes,
you may have picked that. But I did wonder when you were talking, when they go to the ICU and we're really loading them with antibiotics. Are there now recommendations of like replenishing with probiotics or something? Is this something we should be doing post real therapeutic antibiotic regimens?
And so in those cases, so infectious situations where we're treating with antibiotics, we think there's an infectious process that happened. I do think it's appropriate to do like a 14-day course of a probiotic. And often when we do antibiotics, we use that in general because we know it upsets the stomach and we kind of have changes. And again, I don't think there's a risk with it. How much is it actually doing? I don't know if we necessarily 100% know, but I do think there's a role, for example, in those cases, because we do know it's specifically affecting the microbiome. We are changing the gut kind of bacteria there. And so doing like a 2-week course is appropriate. You know, different than doing like a 5-month course for something we're not sure it's going to do.
And I have a last question wondering here. The budesonide oral, I have no idea of the dosing. I don't manage these patients at all. But Dr. Kinan has been talking about, we don't really think it's asthma, just by the way. A lot of our patients are being diagnosed with asthma, but they have emphysema, hypoalveolization syndrome, they have lack of surfactant. It's a much more complex picture, and they tend to be treated the same as asthma in a way. So to that is that they get put on Flovent, and what we like, budesonide is also a medication that has been used. We like the HFAs because they have surfactant to aerosolize this drug. So Dr. Kinan has been using regular puffs and has gotten some of these kids that were really stuck on a ventilator even, to serve. We don't know if it's that or something else, but I would say by now I'm almost convinced that we do something with this when they're requiring respiratory support, for example. Does that go to the esophagus if we're doing
yes, the concern with it is that when you're spraying it right into the mouth, that it can kind of affect the posterior more and issues with like yeast and stuff like that. But we do have patients who will use a spray, and if it can be
2-in-1.
What?
2-in-1.
Yeah, exactly. So if you're saying, well, we actually want that effect because we want it to go in the airway too, but you can swallow it, so what we will have patients pump and swallow, and that can certainly get into the esophagus. The question, are we dividing and conquering those? Not enough getting into the airway because you're swallowing afterwards, but it is something that we have patients do sometimes.
Cool. Thank you.
There's a Zoom question. I also have a question since you have the mic.
Great.
So Raceland, his gut is probably, it is our second biggest problem. It's a massive problem for him. He's on a huge regimen just to, get through the days. We do probiotics just because he has frequent hospital stays. He's always on antibiotics. But one thing I wanted to say is that every time Raceland's in the hospital, or even when he's not in the hospital and he's on antibiotics for 7 to 10 days, he gets very, very bad diarrhea, and then we get over it. But the important part of this is we always see a swing in the opposite direction as soon as he gets off, and that tends to be his highest risk time for these obstructions. We have to, even though he's coming off of antibiotics, we still end up having to do like extra citrate or flushes and things, because by the time he's past that, we're already in trouble.
And that's a good point. So a couple of things with that. So antibiotics are usually pro-motility. They kind of speed everything up in the gut. So we'll often see that. Also with infections, the infectious properties slow down the gut, right? So you're kind of having two things happen at once. But you have the antibiotic, so it's kind of helping move things along. You get rid of the antibiotic, you're still left with the infectious aspects of the gut and kind of a slow moving gut that takes a while to recover. And maybe in this case, takes even longer to recover. So there are cases like yours where we say, okay, let's prophylactically kind of manage that because we know this is how the body responds now that we've been through this multiple times. Let's do extra doses until we feel like that gut has really recovered from whatever infectious process just happened. So that is a common thing we do see. Or I'll have patients who say, oh, they're great on antibiotics. Let's just keep them on antibiotics all the time, which we can't do either. But it's certainly kind of that balancing of the pro-motility aspect and then the dysmotility we see with infections.
And it's just kind of wild to see the swings. We just have to manage it so closely.
And some guts are just more sensitive too, which can be true.
That sounds like Graceland.
Yeah.
The Zoom question is the last two talks have focused on GI, but do we have more information on gallbladder sludge and stone formation and ways to prevent the sludge or stone?
Yes, that's a good question. I don't know that data, honestly.
We see a lot.
Yeah.
At least it's a big part. So we have a lot of patients with that, at least the sludge, like gallbladder, and then stones. And there are several patients with cholecystectomies in the cohort. And they seem to be young, no? Like they're getting cholecystectomies less than 30 years of age. That might be the disease or not. It wouldn't be surprising. We have some dysmotility, a sphincter or whatever.
Exactly. Sphincter of Odie, yeah.
We have not seen cholecystitis. Like I gone through a lot of medical records and the diagnosis is not there. So there's gallbladder stones or sluggish things, but they're usually treated even with resections, but not because of severe presentations.
Do you see it in younger, because we'll often see it in we say females often have it, 20s will often see
No, kids.
This is okay, so
this
kids,
is
that's
even like less than 2.
Oh, interesting, yeah. It's an interesting thing about because smooth muscles everywhere is GI tract, so especially sphincters that I mentioned. So you have the sphincter connecting to the gallbladder. Are there things kind of is that tighter? That's been my question this whole time. Are we dealing with tighter sphincters because of the abnormalities in the smooth muscle and the enteric nervous system? And so maybe there's a backup there. I don't know the data or what research has been done on that.
Send it your way.
Yeah.
I don't know.
Any other questions? We're good.
Great. Thank you so much.